I'd like to welcome everybody to this week's seminar hosted by the UCD Research Partners team. It's part of our COVID-19 research seminar series that we started about a month or so ago. The purpose of the series is to highlight some of the great COVID-19 related research that takes place across UCD's 6 colleges. And also we hope that it will help facilitate greater interdisciplinary collaboration within UCD and also with any external partners that are interested. As you might be aware at this stage, if you're a regular attender, the series takes place each Wednesday at 2 o'clock. And we will continue to do so until Christmas time and then very much into the new year as we add more and more people to the agenda. The format of these sessions begin where you'll hear from our guest speaker, and then we'll move on to a short Q&A session from the audience. And if you want to have any questions, you can submit them via the Q&A function at the bottom of your screen. So without further ado, I'm going to introduce our guest today. He is Professor Brian Caulfield at UCD School of Public Health, Physiotherapy and Sports Science. He's currently the director of the SFI Insight Centre for Data Analytics at UCD. And his research is focused on the application of digital supports and data-driven technologies for a better understanding and enhancement of human behaviour and performance in health and sport. Prior to his current role, Brian also served as the academic director of THRIL, the Technology Research for Independent Living Centre, which was a large academic industry collaboration involving UCD and Trinity, Intel and GE Healthcare. And that was aimed to understand how digital could support successful aging. Brian also serves as the principal investigator in the Arch Connected Health Technology Centre, and he was also the Dean of Physiotherapy in UCD from 2013 to 2019. So today, Brian is joining us and he's going to be talking about his COVID-19 related research that focuses on the use of consumer fitness wearable data and its use to detect early identification of influenza-like illness. So I would like to welcome Brian and hand over to him now as he tells us about his research project. Welcome, Brian. Are you well?
Thanks very much for that, Kevin, and welcome everybody. I just want to give a kind of a bit of a brief introduction to begin with into some of the motivations for our work and talk about some of the similar efforts that are happening across the globe. As Kevin said, I'm interested in understanding how, wearables and data we can get from wearables can help us better understand people and better understand their behaviors and understand how we can ultimately, drive better behavior or drive better health or performance. And when the COVID pandemic hit us in the very beginning, I suppose we were all running scared for quite some time, and like a lot of people in the academic community started to try and understand whether or not their research interests or their expertise may be able to provide some part of the assistance in the global effort or some part of the solution to addressing the challenge of COVID. And like a lot of people, I had a lot of interactions with people in the clinical sector trying to understand how some of our technologies could help. And in a few cases, we ran aground very quickly. We understood that whilst there may be potential for application of some of the things we were working on, it wasn't likely to be meaningful in the short or medium term. But one area that we started to see very early on was the potential of wearable devices and the data that comes from wearable devices to potentially help. And there were kind of 4 different types of activity that we could see that where there was some type of assistance. And the first was in monitoring impact of control measures. And I think we saw in late March or into April, some really interesting examples of the data sets that were provided by Google and Apple that showed us how we could take data from people's mobile phones and understand the impact of different control measures in different countries, different parts of countries, and it's fascinating. There were also obviously some very strong examples of wearable and mobile being used in contact tracing. We are starting to see, in the early days, there was an awful lot of companies who were involved in digital health started to modify their mHealth platforms to enable management of cases and implement remote monitoring for COVID-19 cases. There's actually some really interesting work coming out of done by Madeline Lowry and Emer Dohney in UCD in that. And then the last area was, identifying cases or clusters, trying to understand how you could get data from wearables, plus data from interpersonal mobility and interaction between people, and then also self-reported symptoms to try and, either at an individual level, try and identify the potential onset of illness in an individual, or in the case of communities or populations, trying to identify where clusters were emerging. And that's probably the area where I've been most active since then. One thing that's probably, if I can do a little bit of self-promotion to start with, back in April, there were myself and another Irish researcher were lucky enough to get involved in an international group that was pulled together by Paolo Bonato and Harvard Medical School to provide to look at a scan of the various ways in which mHealth technology and wearables might be able to mitigate the pandemic. We produced a kind of one overarching paper and then a series of, I think, 8 supplemental papers that got published in the Open Journal of Engineering and Medicine and Biology. Took quite some time for the papers to come out, but it's actually a nice kind of overview, which is worth looking at if you're interested in this space. So I suppose today, maybe just to focus in on, whether or not we could use wearables to identify clusters of cases, or whether or not we might be able to use data from wearables to identify early signs of infection, and particularly identify them before the onset of symptoms, so that if a person has an impending infection, that you may take them out of circulation as soon as it's possible. Some work, just focus on some of the work that's ongoing in other areas. There's a lot of work in this area on, monitoring symptoms. Probably the best example is the Zoe Covert Tracker that was developed by a team in King's College in London. That was released, again, very early on in the process in April. You can see they have over 4 million users of the app today. And that involves people on a daily basis just tracking symptoms, very similar to the app that was eventually launched by the HSC here. But the inspiration for an awful lot of this work is the notion that if we are tracking a biomedical signal, in particular physiological signals with consumer grade wearables, we may unwittingly be capturing a lot of really interesting information that could help us identify infections. And an awful lot of the work that is happening internationally at the moment was inspired by a study that was published in January of last year. And I mean, it was just complete coincidence that this research came out the month before the pandemic hit. And it was a group in Scripps who had gained access to a large data set of consumer grade wearable physiological data from Fitbit. They had over 200,000 participants. And to make a very long story short, what they were able to do was to match the data in cases where they achieved critical mass. They were able to match the data historically, going back over the previous couple of years, from the wearables to develop predictive models for outbreaks of influenza-like illness. And they matched the data against they matched their modeled, their predicted outbreaks against the CDC data for actual outbreaks, and found that there was a really strong match, and it was very interesting. It was based on the concept, or based on the notion that, your resting heart rate may change. You may say changes in your resting heart rate in the days before you actually notice symptoms of an infection. Because typically our resting heart rate from day to day is quite a robust physiological signal until something goes wrong. So in April, they launched what's called the DETECT study, which is a crowdsourced study model where they're trying to bring a lot of people to volunteer their wearable data, as well as track their symptoms. And alongside that, if they were diagnosed with COVID-19, to actually confirm a diagnosis of COVID-19. And that DETECT study I'll come back to in a while, because as we're launching a version of that study in Ireland. But at the same time as the team in Scripps were running with this, there were also some other international teams starting to look at the same. One here is a group in a company called Evidation Health. Evidation are a really interesting company that build up very large panels of volunteers for research studies. They have an app that enables you to collect a lot of patient-reported outcomes, clinical outcome assessments, as well as wearables data if you happen to already have a wearable. And they retrospectively went back. They actually were running an influenza study. They have nearly 4 million people in their panel. And they were able to pull out some cases of confirmed COVID-19 diagnosis in the early stage of the pandemic, and retroactively look at the relationships between some of the measures coming from wearables and onset of COVID-19. They also did a really interesting analysis of symptoms as well. So we started to learn a little bit about the relationship between, personal generated health data and COVID-19 in that study. Alongside that, we saw, again, an alumnus of UCD, Conor Heenan, who's in Fitbit, start a research program in Fitbit, where Fitbit went out to their many millions of customers around the globe and asked them to volunteer their data for specific COVID-related analyses. And they published over the summer the initial outputs of that, and that they are now, just in the last couple of weeks, they've announced that they're working with the US Army on a formal program of research to enable early detection of COVID-19 based on deployment of Fitbit in the US military. The group from Scripps published some early data back, I think, at the end of August. The interesting thing to note about this is that they had 30,000 people enrolled in their study, but most of their really interesting data analysis comes from a very small grouping, where they had 54 people who they had retrospective data from and had a confirmed COVID-19 test. And they were able to show that the relationship between the data from the wearable and the and symptoms was better at modeling a positive diagnosis than just symptoms alone. And another grouping out of Stanford have just recently published on again, starting with a really large cohort of participants. They started with multiples of thousands, but end up just reporting a case series on 32 individuals. And again, we started to learn more about the relationship between consumer grade wearable data and COVID. This group have actually made all of their data available on an open data repository for use by the scientific community. So just before I finish up, I want to the reason that I'm here today is to talk about our efforts to bring that Scripps launched DETECT study to Ireland. We have been in contact with Scripps. We got in touch with Scripps, the team in Scripps, the day after we saw their initial press release, when they were launching their study back in early April, and have been working with them since then. And we are part of an international grouping now that are launching versions or legs of the DETECT study in different countries. In Ireland, there's kind of 3 organizations involved in this. There's ourselves in UCD, and I'm working with Professor Tomas Ward in DCU, and the 2 of us are involved in the Insight Centre. And we also are working with Dave Burke, a cardiologist in the Beacon Hospital, to bring this study to fruition. We will be launching a study here. We have an ethical approval and we're ready to go. We're just waiting for the technology platform. And we will be asking people who already have a Fitbit to sign up to the study. We will capture baseline health and demographic information from them. We will get them to link to their Fitbit data stream, and we will capture Fitbit data from them throughout the study. If we did, and we have a real-time analysis of their resting heart rate data. If we see a change in their resting heart rate data, a sustained change in the resting heart rate data for 3 days, we will trigger a symptom survey to them, and we will continue to trigger that survey for 14 days. We also have a symptom survey that can be triggered by people at any point themselves. And outside of that, people will be able to just forget about the fact that they're in the study. Every month, we'll just check in with them just to make sure they still want to stay in the study. And in doing so, we want to build up an Irish data set that we can interrogate on a national level, but equally contribute to the international data set in this area. The reason we're not launching until now is that it has taken us quite some time to develop our own app for this because of GDPR concerns. We're not able to use the US app. We have an app that is ready. It's being tested in the Insight Centre at the moment, and we are ready to launch hopefully by the end of this week. And I have the information, we'll be pushing this out in social media, and we are very keen for people to sign up to it. So hopefully, I don't know how many people are in this webinar, but hopefully we might get a couple of people from this webinar. So that's me done. I suppose I just wanted to speak to you about a study that is just about to start, as opposed to share results from a study with you. Hopefully we'll get a time to talk about why it's taken us this long to actually launch this study. So thank you.
Thanks very much, Brian. That's great. I think I might start by asking the process for you working with people's data, essentially. So I presume there's a level of having to engage with the research ethics committee and whatnot. And was that part of the delay that led to here, or?
No, actually, it wasn't. In April, UCD, I think, reacted very, very quickly to the pandemic, and the UCD Research Ethics Committee actually had a fast-track stream for applications for research that were related to COVID-19. So we actually received ethical approval for this study within about 14 days of us having our first phone call with Scripps.
Okay.
That was actually the most efficient part of the process. It was GDPR concerns and having to piggyback on existing software development activities, as opposed to, you know, having the capability to devote a lot of resources to building a dedicated app for this, is what has taken us this long to actually get started.
Yeah, you're essentially ensuring that anyone who participates, their data is protected before you launch. Absolutely.
When we had our initial discussions with the team in Scripps, they very quickly made available to us all of the study material, their full cooperation with the collaboration, to the extent where the third-party organization would develop the app that they were using. They made that available to us as well. So we had a free software platform that was ready to go. However, when we presented that and the data pipelines underpinning it to the DPO in UCD, it was very clear that that wasn't going to work for us. You know, the data would have been hosted in the United States, which is just inconsistent with, you know, giving participants in a study reassurance that their data will be protected.
So, I mean, obviously you're trying to join in on a global study here on our small island of Ireland that it is. How do you foresee, once everything's launched, how do you see the take up in the country in terms of, you know, getting the right sample size to get as much meaning out of this as possible in terms of what's realistic for your project you envision for this?
Yeah, I mean, I think what we're seeing here, and I think, you know, as the months have gone on since April, what the studies that I've just shown you very quickly have demonstrated to us is that it's unlikely that we are going to achieve, statistical power here in terms of predictive models. It's highly unlikely, even if we got every Fitbit user in the country. I think it's unlikely, because when we see, in the case of the Evidation study, they start with 70,000 people. In the Scripps study, they started with 30,000 people, and then they end up, dealing with 60 cases of confirmed COVID or 40 cases of, confirmed cases, where you're talking about a very, very small number of data points. I think there's two things that still make us very interested in doing this. One of them is that even if it's in a relatively small level, we can contribute to the global data set. And there's more power in greater numbers. But at a local level, we plan to do, I think a deeper analysis in the case series than has been done on the other studies up to now. In most of the existing efforts, people have been focusing on the daily summaries of your consumer wearable data. So looking at your resting heart rate for a day, looking at your total activity for a day, your total sleep for a day. What we're really interested in here is the intraday activity, looking at the, hour-to-hour variation. In fact, even at a smaller epoch than that, we've done some work in Insight on interrogating consumer and research grade wearables down to much lower epochs. We go down to a 15-minute epoch, or sometimes down to a 1-minute epoch, and we're looking at a person's activity profiles and patterns of activity profile over, much more granular way. So we think we will be able to shed some new light on it, even if we're dealing with a small data set.
Yeah, very good. Do you think it will get to a point where you'll be able to predict the potential onset of COVID or other illnesses like it using this data, if it's powerful enough? Or
I think eventually, yes, but I don't think, I'll be completely honest, I think that the early analyses in those few papers that are out already are showing us that we're not likely to achieve the critical mass within the term of this pandemic, but ultimately I think we will achieve that level of predictive capability with wearables. But I think, you and I could be having this conversation next year and we will not have a really strong predictive model for giving you 48 hours advance notice that you actually have become infected.
And just, is there, like you talk about Fitbit captured data, is there a means, or is it possible in the future, and I don't know, whatever different ways data is captured by other devices such as a Fitbit, that other data sets that aren't Fitbit connected or related or derived could be brought into the study?
Absolutely, yeah, absolutely. It just comes down to bandwidth and software development resources. I don't think it's possible to, like in our case, the Fitbit is the easiest API, I would say, to work with. Some of the other companies, like, I suppose the other big ticket manufacturer here is Garmin, and Garmin's API is, wouldn't describe it as open and available to the research community.
Okay, very good. I have a question from the audience here. In terms of the profile of the participants in the international studies, do they kind of represent cohorts most vulnerable to COVID, typically? Consider it as large numbers and then boils down to smaller numbers, I would imagine.
I think they do. I mean, in our discussions with Fitbit, my understanding is that the distribution of their customer base is not even across the age profile. They appear to have a lot of users in the very young population and a lot of users in the older population, and not an awful lot in between. Now, I haven't seen a very detailed breakdown of this. This was just in conversations with them. So in that regard, the younger population absolutely would not fit the profile, but the older population would would fit. Yeah.
Is there, I presume there's a way in terms of analytics to kind of separate that out and see if there's further trends, is there?
Again, if you can achieve critical mass, we do capture age as part of our core data set.
Mm-hmm. Okay, very good. In terms of then promoting the study, now it's kicking off shortly, you say at the end of the week. Do you have plans on how you're best going to get the word out there? And
yeah, so primarily social media, and if we can generate some interest, the Insight has a communications team, and they will be trying to hit the more traditional media as well. So hopefully we may get a bit of traction. The timing of this is interesting. I mentioned to you that we initially expected that we would be able to launch this in May, and then when we realized that we were going to have to work on the Athena CX platform, which is actually an experience sampling platform that Tomas Ward has developed as part of in fact, the company behind it is part of the Big Ideas showcase today. But it was not developed for this purpose. So we have had to kind of fit a square peg into a round hole. But we then thought, oh, maybe we'll capture the going back to school. And now we think we might capture the reopening of the country for the second time wave. So we're trying to look on the bright side of all of our missed targets. But we hope that it might generate a bit of interest because of what hopefully we'll be doing next week.
Yeah, very good. Has anyone got any other questions that I didn't cover?
I see a question here on the chat about...
That might be the one I asked.
Could it sense a cardiovascular event or hyperglycemia, hypoglycemia? Actually, just on that, we have a similar study that we will be launching in January. We just received we've just responded to the ethics committee, but we anticipate that we should get ethics approval for a similar study where we will have, instead of it just being an observational study, we will actually trigger in interventions in heart failure patients with David Burke in Beacon Hospital in January.
Very good, excellent. Okay, well, I think we might, we have one more question. What about using retrospective data? Is that possible? Is there access to that, or is it a GDPR concern in terms of consent? Or
yeah, the way we're running this study is that it would be possible, but it would require more active input on the part of the participant. People who sign up to this study, we actually will never know who they are. We don't, it's not like our traditional study where we will get signed consent. We get digital consent here from people, and the only point at which we would ever be able to identify a person in our data model is that if a person wishes to withdraw from the study and wants us to remove their data from the data set, they press a button in the app that generates a unique code for them, and they email that unique code to us, and then we remove them from the data set. And that's the only time we ever have a contact with a person.
You get that email from them.
There's no interactivity here. So when a person signs up to the study, there is a model that would enable us to access their retrospectively. We can reach back if they give us permission to access their Fitbit data. We can reach back into the historical data. We're not currently planning to, because annotating that data would be very difficult. And now if somebody was to say to me, I had a positive test on the 17th of May, so you go back to the beginning of May and access my data from that, then that would work, but that would require a lot of things to fall into place for us to be able to rely on the data. So we are actually looking at a prospective model rather than a retrospective model. Retrospective would work, or could work.
Yeah, I guess it's good to have that access in case you want to go down that road. To look retrospectively. I mean, obviously it'll take a bit more work, but to know that it could be an option if need be, in terms of getting consent.
Absolutely, and I think that's a very important thing for people to understand with wearables. Even though the system has not truly understood, we don't have a body of knowledge that has enabled us to truly exploit the data that people are capturing with these devices yet today. We will hit a point where, like today, if you turn up at your GP's office and you say, I've got a Fitbit, do you want to see my data? The GP will run scared. But we're not very far away from a time where the GP will be able to say, oh yeah, I'd love to access the last 6 months of your data. And actually run some models on it so I can actually learn something from it.
Yeah, that'd be interesting.
That retroactive, that data that you are generating today will eventually be useful.
Yeah, even in the home setting, running models yourself, that could be a really interesting thing, just out of curiosity. Well, look, thank you very much, Brian. I think we've come to the end of the time. Thank you very much for presenting and answering our questions. And thanks for everybody who attended today, for your interests and your time and the various questions for those who provided them. If anybody would like to continue the conversation or ask any further questions, you should have been able to sign up to the Basecamp team around COVID-19 that we run, and you should be able to put something on the message board there, and we can check that and get it to where it needs to get to. I'm also up next week hosting for the Research Partners team. So if you'd like to join me again, we have 2 speakers next week, as Professor Ronan Cahill and Dr. Kevin Nolan, and they're going to be talking about their research involving advanced imaging techniques to understand the transport of the COVID-19 virus in the air. Okay, well, thank you very much, everybody, and we'll come to a close. Thank you very much, Brian.
Thank you. Take care. See you, everybody.